So what I'd like to do is just to start off with, highlight an issue here, which as a central issue, we'll come back to this. It's a complex slide, but effectively, this is about a joint strategic needs assessment, which is the beginning of getting your priorities identified and who your vulnerable people are, both internally within the serving population and their families, the reservists and their families, and then veterans and their families. What I've done is taken what is a population health-based approach. We've segmented the population to help try and identify different needs for different categories of people. So the elderly, adults and adults with long-term conditions, working adults, maternity, and then children and young people. They all have a slightly different need in terms of service needs. And what I'm suggesting is if we use this framework, we can use it both within the military and serving units, but also within the reserve units, because the reserve units have got a very different challenge on their hands. So we've talked to particularly 254 Medical, our local unit in Hitchin, and when they're serving, they're under the MOD, but their families aren't, they're in the NHS. And when they're not under the MOD, they're in the NHS. And one of the big challenges is keeping them operational, and particularly accessing services like dentistry in order to stay operational. So with the delegation of primary care from NHS England to integrated care boards, there is an opportunity locally to try and look at how can we contract with dentists, how can we contract with community pharmacists in a different way that meets the needs of the military community. So I think there's some real opportunities there. And that's true for the delegation of specialist services, which I'm leading on for my ICB. And those services are being delegated by NHS England. So we will hold the budgets from April 24 for some specialized services on cancer. So that comes back to the targeted lung health check program, for example. So ICBs, from a health point of view, a healthcare point of view, are really crucial about joining this up with the local authority services. The Office of Veteran Affairs is the glue and the policy setting agenda that brings Whitehall together at the very top level. And we've got Tom Varney, who's in the Cabinet Office, part of OVA. He's part of our virtual group today. But I wanted just to make sure that people understood that we now have an Office of Veteran Affairs, which has got oversight across the whole of the agenda in terms of MOD, all the departments of state, and particularly the Health and Social Care Department. And Richard is, in a sense, the link person, the doer, who links in with the OVA. The OVA are setting the agenda, they've set the strategy nationally, but at the ground level, we need to do some of this basic needs assessment in order to identify who are the vulnerable people, who are the ones that need the most support. And as I was saying earlier on, one group in particular are carers. So knowing who your carers are in the family setting, who are looking after frail elderly relatives or are looking after disabled children, they're the ones that really need personalized care planning around them. That includes things like housing and education and not just the healthcare bit. So I'd like to just, this is a simplified version of what I've just shown you in terms of understanding that segmented population and our three groups. But what I'm suggesting as of today, if you go back to your unit, but also you go back to your locality, we need to be doing some joined up joint needs assessment and identifying who the priority vulnerable groups are. So these are some of the key pathways that I think we need to look at. So for the elderly, it's dementia pathways, end of life pathways, mental health pathways, and particularly where we want to get in with early intervention for preventing anxiety, stress, and particularly CBT is a very strong evidence-based intervention. Addiction services is a general term, but it is really quite important at the moment, particularly with the cost of living crisis. Gambling is coming up, and there are some, Diane mentioned, looking at how do we actually get capacity and specialized knowledge available for people who have got a gambling problem. And with modern IT and the rest of it, it's not just adults, it's children. And dentistry, I've mentioned, One key area where I think we could get some quick wins on is maternity and maternity pathways, particularly for serving families linked to their local community midwifery service. I don't think it's joined up as well as it could be. And I think that's one area where, and we've certainly had that in terms of Carver Barracks asking for support on perinatal services for women who are going through the pregnancy but moving base. And then child and adolescent mental health, and we'll come on to the pupil premium at the end. But you can see that one of the issues there is about how do we join this up? And I'm saying the starting point is doing your local needs assessment. So I'd like to hand over to Aaron, who's going to talk us through the CT.
Good morning, everybody. Thanks for inviting me. I've had a fair travel up, so I'm covering for my colleague Louise Briggs, who is the regional manager of this area, who has temporary promoted, so we've had some management changes. So I actually cover the south of England, and I'm based in Cornwall, so I had a nice sunny drive yesterday. It's amazing how far you can drive and still be on land, east. But I've got my colleague with me here today, Mark Haining, who's now going to be the Southeast Regional Manager, so I will at least be getting my region cut in half because it's quite big. They didn't tell me what the military footprint was when they gave me the job, which was a bit of an eye-opener. But today I'm here to talk about veteran services. I know I've got 5 minutes and I've just wasted a minute of those already, so I'm going to crack on. He says. So, what are veteran services? Well, we're part of Veterans UK, and we sit within inside of the Ministry of Defence, and we are the Ministry of Defence's Transition Support Service. We sit within DBS, Defence Business Services pillar. I'm going to try and do my best with acronyms, but it's almost impossible when you've got the multiple acronyms that we use for various different things. And so Veterans UK sit within Defence Business Services, and inside of Veterans UK we have Veteran Services. So Veterans UK essentially, if you look at it, they have an ops department that's in Norcross near Blackpool, and they make the decisions on the Armed Forces Compensation Scheme payments, war pensions, etc. And that what happens is a lot of people get confused and think we as Veteran Services are part of that as well, but we're actually separate from that. So the Veteran Service piece is around supporting individuals with their claims. We don't actually make decisions on that. So in terms of who we are, we've got 3 main services. I've got to start looking down that way. So we have VWS, which has been going since 1948 and was originally set up to provide one-to-one support lifelong for veterans and service people going through medical discharge, bereavement, death in service, and supporting with disablement finance and housing. In 2019, we also set up the Integrated Personal Commissioning for Veterans, easy to say. And that's a specific bespoke service that operates internally within the military to pick up those most severely injured within service to ensure that when they come out of service, they are supported till end of life. So those individuals will need 24/7 lifetime care. We have consultants that are based across the country that will essentially head up multidisciplinary teams to ensure that care is coordinated. And also, depending on the tier they're at, in terms of their injury, they may also have a small amount of funding that they can utilize the caseworkers in terms of purchasing equipment like specialized wheelchairs, for example, that aren't available on the NHS that would be above and beyond. Also in 2019, my service, Defence Transition Services, was set up, and that was off the back of the Veterans Strategy. We have a policy within main building called the Joint Service Policy 100. And essentially that's looking at how we could support individuals leaving services that are likely or identified to be vulnerable to ensure they have the most successful transition as possible. So that's essentially what we do through that piece. So in terms of referring to us, as I mentioned, we pick up those, I don't necessarily want to use the word vulnerable, but it's difficult to necessarily identify exactly who we'd pick up, but it's individuals that are often short notice discharge or unplanned discharges, where they've got no idea that they're going to be discharged, and therefore they haven't got a housing plan in place, they haven't got what they're going to do for work, and all these things that make life considerably complicated if you're coming out of service anyway, regardless of whether it's planned or not. And Veterans Welfare Services will support veterans up to the end of their life and assist with injury and bereavement compensation payments. So in terms of referring, if you're in service, majority of our referrals come in service from unit welfare officers and other services. And they come through on DTRP, which I'll show in a minute. So DTS operate 2 years pre-discharge and 2 years post-discharge. They set us up in a very similar window to the Career Transition Partnership. You could obviously argue that transition goes on for much longer than that, but of course we have to have some kind of time frame to operate from. And VWS and IPC 4V goes for as long as it is required until end of life. So we have a number of referral options into our service. So the DTRP1, I said I was going to not do an acronym, but we're straight into it. Defence Transition Referral Protocol is for in-service individuals. So that's primarily those with a ModNet referral email address. And there is a self-referral form. So other organisations who come across individuals that within two years of discharge can refer into us through that process. We, of course, straddle the line between in-service and outside of service, so we can have and engage with chain of command around specific types of issues and see what we can do to try and alleviate some issues that people may have. For example, if they are being discharged under an admin discharge and the unit wants them out, if they haven't got housing sorted, we can have a conversation with the unit welfare officer to see if there's a possibility of holding on to that individual for a little bit longer so we can get them squared away in regards to housing. We also, as you can see there, have a helpline. We also are linked in and get referrals from Veterans Gateway, and we have regional centres across the UK as well as central email addresses. So in terms of delivering support, when we receive a referral, we have 2 days in which to engage and respond to the referring officer. Then we'll make initial contact with that individual and then provide a holistic needs assessment, and we call that hard facts, which is an acronym for which will come up in a second, but essentially looking at a welfare needs assessment the majority of individuals in this room would do for their service. And then off the back of that, we'll then create an action plan based on that individual's circumstances in terms of what support they may require and also where they're going to relocate to, because obviously not all services are available, so it is dependent on your postcode. Although obviously with the introduction of a lot of the services from NHS, like UpNova upcoming, Up Fortitude coming with the housing, there are elements now that's going to be much easier in terms of pathways into support, which is going to make things considerably better for us. And then what we'll do essentially is through that conversation, we're trying to empower those individuals to engage with those organisations. So signposting is a wonderful thing, but often with a cohort that we pick up, we give them some fantastic advice and then they won't follow it. So we need to have ongoing conversations and encourage, I'm sure I'm seeing some smiles here from people, ongoing conversations and encouraging individuals to pick up the phone, to engage with those services, or we'll make the referral for them if we can, just to ensure that they are engaged, they're referred, and they're moving forwards in terms of their support needs, whether that's housing, mental health, drug, alcohol, support, any of those elements that come up in welfare. We obviously work collaboratively with other organisations, but we don't deliver a service specifically ourselves in terms of our support is really around directing and introducing people to their options so they can make informed choice themselves on what they think is the best option for them in terms of the support that's out there. And then we support those individuals, as I said, in DTS up to 2 years and Veterans Welfare Service for as long as they need. That's an idea of the holistic welfare assessment that we would do. Training and employment really sits with the career transition team, so we don't do a huge amount with that unless the individual has specific complex needs or has, for whatever reason, opted out of that support service. And obviously that runs for 2 years, which is the same time frame as us, but we will refer to other organisations if appropriate. In terms of the welfare service, I'm going to fire through this piece, but essentially, as I said, they set up and they have welfare managers dotted around the country that will go to people face-to-face if required and support them through the application process for the war pension application or for the Armed Forces Compensation Scheme. The difference between the two essentially is that the Armed Forces Compensation Scheme came in post 6th of April 2005. You have a limited number of reviews through that process, and also you have a 7-year time frame from the incident, if it's an injury, in which to claim. So a lot of individuals, unfortunately, we see coming out of service have waited to their end of service to make a claim, but then have passed that 7-year time window, which is a really difficult thing to hear. So we're trying to broadcast that whenever we do internal engagement within the services. They're also experts in fortunate pensions. Don't ask me any questions about pensions because that's not my area of expertise and it's completely complicated, especially when medical discharge is involved. And they also will provide a death in service support. So they will go and see individuals after they've been notified of the loss of their loved one and support them through that probate process. So quick, what am I looking on time? What, a minute? Oh, great, okay. I should have given you that 5 earlier. I could have got a bit more time. So in terms of a case study, this is an individual I personally supported. So he came out of he was a CDT, which is compulsory drug test failure. So they're often very short notice discharges. I did speak to the unit and they were really good, and they actually held on to him because we hadn't got accommodation sorted for him. He didn't get his resettlement advice brief, which is something you're supposed to have to get engaged with CTP support. So after he was discharged, we had to feed him back in and make sure that was done so he could get employment support through CTP. And then a lot of my conversations with him were around housing, because he was initially being directed to go to supported housing. I don't know if people are aware, but supported housing is quite expensive. The rent is a lot, so actually that can be a barrier to gaining employment, because you can't afford to pay the rent if you get a job, but you'll be covered if you're on benefits. So we looked at Spare Room, which is a website where you can find shared room options. He got a property place through there, and he paid his initial deposit, and things were going well. He started his job, but he was starting to run out of money at the end of the month because he'd paid his money from the end of his check from the army, essentially, to cover for his deposit. So we went to RBL, and RBL said, yeah, we can assist you with some food vouchers, but because he was working, they kept calling on days when he's working, and we couldn't get the process through. So I basically picked up the area team leader's number, gave them a call, said he's off work on Friday, give him a call then, and then they got it sorted. So often a lot of what we do is around just finding key people within organizations where we can get things moving if we have blockages or things stuck. He also then got told he had to move out the property, so he then needed to find a new property, but as he'd been injured in work, his landlord had essentially used his deposit, so he had no money for a deposit or rent, and he was potentially facing homelessness again. So I went to his regional mental association, and again through RBL, we got £1,500 so he could get 1 month's rent in advance and a deposit, and that's not something that he would have thought of doing himself. So it's around looking at what we can do in terms of advising them in their best place and what options are available, and it of course is on a case-by-case basis, as well as ensuring that you register with his GP and other elements like that. And so he's 18 months into his sport. I still speak to him pretty much every week, because he's again, funnily enough, on being evicted in a couple of weeks again, as he keeps making not the best choices. So we're working on that in the minute, but he's just got a job in Butlins. And actually that could be quite good for him, because there's a similar kind of dynamic with Butlins, and the fact that stuff's gonna come out straight out of his paycheck. He's going to be in accommodation with the team. So it's a lot of similarities to the military side of things there. There's a quick number on stats. So we were set up initially to pick up 3 to 5% of total annual discharges, which are up to 15,000 a year. So not a huge amount. So we don't have a huge amount of staffing, but we are currently under 2 ministerial reviews. So and those are looking at how the support we provide and how many staff we have, and putting some sort of structure, especially around the Veterans Welfare Service, because we've been asked to do more and more things there. And essentially, at some point we need to have some boundaries and understand what our responsibilities are, because that doesn't sit within a policy. So those are things that are going on currently, and a likely outcome of that is somewhere towards the end of the summer to the end of the year. That's me. Thank you.
Thank you very much, Darren. And apologies for getting the acronyms mixed up, but there clearly is a lot of support out there in terms of trying to organize things before people leave the service. And one of the things that Aaron was saying is that we're talking about 15,000 people a year. So that's potentially a huge workforce that certainly the NHS and the police and local authorities are looking at. The question is, how do we connect it? And we'll come on to that at the end of the conference. I wanted to really go on to the family strategy. The Office of Veteran Affairs and the MOD produced the family strategy. I'm sorry, very small writing. But the really key message behind this is how important families and personal relationships are to supporting frontline personnel and keeping them going. And that's the crucial bit here, which is actually about how do we support and make sure that the system locally is supporting families, both serving and in the reserve, as well as those in veteran space. So we're talking about here families that are serving families and also reserve families. Across the east of England, as I said, we've got about 15,000 serving personnel, and probably around 35,000 families in terms of personnel, children and significant partners. The really critical bit here is how do we help identify and help them? And the strategy has set out a number of principles which are linked to the Armed Forces Covenant. And I won't go through the covenant, but the issue here is about mitigating disadvantage, which is the fact that a lot of them are mobile and they're having to move from base to base. And one of the things is that they don't have any settled school, they don't have settled GP, and that's one of the issues where we in the local authority and the NHS can make a big difference if we can help join it up for those people who are moving rapidly from unit to unit. I'm talking every 2 or 3 years. And that's particularly true where you've got a child who's got special education needs and is waiting statementing. They can often be in the queue. By the time they get to the front of the queue, you've moved to another unit. It'll be the same for housing. So one of the issues here is about continuity and recognizing in terms of the local Armed Forces Covenant leads for each organization, how do we give some stability and continuity to these families? And I think that's the crucial message behind this. The strategy says it's got a dual focus. One is to inspire partnership working, and that's what we're here for today. Honoring the endeavoring pledge of the Armed Forces Covenant and to provide direction to policymakers, single service and public service providers to empower armed forces families to live rich and fulfilling lives. At the moment, we know that they've already got problems within the MOD in terms of housing stock and how housing's working. We've got exactly the same across the housing market in the UK with rent and availability of affordable accommodation. We've got the same crisis going on in a similar crisis going on in education in terms of how do you get consistency in educational for your children. And I think the OVA and MOD, the pupil premium, is an attempt to try and recognize that. And they've just put out some additional guidance on the pupil premium. There's upwards of 80,000 people, 80,000 children are entitled to that. Not many are actually claiming what they're entitled to. It's £335 a year, but you're also entitled to claim it up to 6 years of leaving the service. So it's not just for those who are actually serving. The key message for me here is delivering a range of practical interventions designed to strengthen and improve policies and services is exactly what we're trying to do here, is getting people who are armed forces champions in different organizations working together to do problem solving on cases such as the one that Aaron was talking about. And we have, and Ashley could talk to this as well, dealing with a young guy who was discharged from Woolwich, no house to go to, going through a divorce, no job to go to, no idea what he was going to do. And he had no idea what the range of services that were out there, and actually sorted him out. I mean, literally sorted him out, yeah. I think the defense plan and the defense people strategy, to me, underlies, so they're looking at deliverable, adaptable and sustainable workforce, maximize the use of talent. Those are those who are delivering frontline defense. The reason they can do that is because they're supported by their families. And so building a stronger, more effective collaborative people function is a critical one for all organizations, not just the MOD. And I think it's true for the health service as well. So the UK Armed Forces Family Strategy is therefore a key enabler to deliver the defense strategy. Some examples here. So relationships in the military at the moment, 49% married, 24% in long-term relationships, 3% separated, and 20% single. So these people all have relationships that they need to support them on the front line. We have 24% of children under the age of 5 and 35% between 5 and 17. So you're looking at primary school and secondary school in particular, and that's where you need some stability. And that's one of the issues about how do you give that to children and still allow serving personnel to continue with their career. 49% are working full-time. That's the spouse and the serving personnel, and 19% part-time. But if you look on the right, this is feedback from a survey done in 2022. 51% don't feel they're valued by the service. This is the families feeding into the family strategy. 27% dissatisfied with the support they've received so far, and 17%, this is reservists, their family would prefer them not to be in the reserve. So there's pressure there. And that's why it's important that the NHS and the local authorities together actually offer coordinated support and partnership working in order to actually allow our country to have the best people in the front line and support them properly. And sadly, 29% would be happier if their partner left the service. Now, that informs what I think is one of the key issues here. Across the UK military, we've got 121,000 children and young people, 5,000 of which are abroad at any one time with their families. As I said, we've got about 80,000 who are eligible for the pupil premium, and you can see that one of the issues there is about how do we use that. It's mostly for pastoral support, and it's not a big amount of money in terms of making a big difference to the individual, but the schools can use that where they've got upwards of 4 or 5 or 8 military families. They can use it in a different way for trips and music lessons and things like that. So it is worth looking at. And locally, we've made contact with 5 schools within our patch through our single point of contact and what's now called Op Connect, which is actually trying to work with the unit welfare officers around the needs of the families. And I think there are 2 distinct parts for that. One is formally, and the unit welfare officers know what some of the issues are. And then the informal bit, which is actually, there may well be opportunities where partners or spouses may be looking for help outside of the military environment because of personal and confidential reasons. And clearly those 2 areas need to be understood by both the NHS and local authority as well as by the MOD. What I've tried to do is link here to the Local Authority Armed Forces Covenant Board, where under the Armed Forces Act 2021, they will have set up a housing lead. They will have set up also an education lead, and they will have a health lead, and I'm the health lead for Hertfordshire and West Essex. So one of the things we want to do from this conference is make sure you know who those people are in your local Armed Forces Covenant boards, because they're the people unit welfare officers need to work with on housing issues and educational issues. They're also the people that the reservists and their families need to work with as well, not just the veterans and their families. And we've got, under the voluntary sector, we've got a huge range of services available that are highly specialized and very specific and catering to specific groups with specific needs, including children who either could be bereaved or children who need support in the military family context. And you can see one of the things here is also the link to the Armed Forces Board with the police, where and certainly for the Health and Justice team, the sexual assault referral centres, custody and what to do with the veterans and military personnel in custody, but also missing persons, which we'll come on to. So I've done that. That was the slide I showed earlier on about the need for a joint strategic needs assessment, and this is particularly important for getting into what are the needs of families on base and off base. And some of the bases, the majority of the families live off the base, not on it, and they're an integral part of the community and linked to both primary and community services. One thing which I'd like to just touch on here, and that is a really important area I'd like to go away from today with, is around suicide and suicide prevention. And we'll come on to that in the local authority section as well. So I make no apology for doing this twice, because the stats are horrendous and they cover both serving and veterans. So we've got 2 groups in particular. One is too many, and One Life Lost is Enough, the Ollie Foundation, who are here today. And I just have a look at the stats. This is for suicides amongst the armed forces community, both veterans and serving, over the last, since 2017, and obviously up till March 2023. But you can see on the right the totals. 2017 only had veterans, but from 2018 we've got veterans and serving, and you can see the numbers there are really quite shocking. So as of last year, 2022, we're looking at 41 veterans and 15 serving personnel committed suicide. Now, potentially this is preventable. Local authorities have suicide prevention boards. Some do have very active ones, and you'll hear from the Hertfordshire one later on in the local authority section. But this is where we really do need to pull together and identify vulnerable individuals and help with what is a sort of wrap around the family service and not just the individual, because it's the family that support the individual. And we'll come back to that, those numbers later on. So I'd like to introduce Ashley Manning, who talked about the social prescribing, but Ashley is also one of the leads for what's called a single point of contact. This is a pilot initiative set up by NHS England following a survey that was done with armed forces families 2 years ago to try and make sure that the NHS was making services available and joining them up as much as possible with military families. So working with serving units, and we've got Northwood headquarters and Carver Barracks and reserve units. And we've got the 254 Medical Reserve Unit in Hitchin. And we've also picked up responsibility for another reserve unit, which is outside our patch, but on the edge of it. But 75% of those people live in our patch. So one of the issues here is about how do we join that up? And Ashley's going to talk about what we've been doing.
I think Harper stole most of my presentation there, so I'll just expand on it a little bit more. So what is the Armed Forces Local Support Helpline? I'll just pop that up on the screen to have a quick read. So essentially, we are a single point of contact for anyone in the Armed Forces community. So that's serving, reservists, families, carers, veterans. We want to be covering the whole Armed Forces now. Currently, we're open Monday to Friday, 9 till 5. You'll notice up on the screen, we've got a 48-hour working response and then a 5-day to complete that referral. At the moment, we're a lot less than that. So anyone can come into that service. The referrals are not just from professionals. It is self-referral, it's professionals, it's friends and family. It can come through anyone. Nearer the end, there is a single phone number and a single email address. We've been speaking about acronyms and this is full of it, but any longer and it'd go off the screen. So what can the single point of contact assist with? So it's a continuation of treatment, maintaining NHS places. It links in the social prescribing of what we spoke about with HCNS, supporting with housing and education, community-based social support, and we're also hoping to promote the veteran-friendly accreditation process across Hertfordshire and West Essex. So, as I just said, is it only available to veterans? When just before this project started, HCNS did have a veteran community project, and that was our main focus. Now with the NHS funding and being able to expand to single point of contact, we're covering the whole community. So how did we initially start making people aware of the helpline? We started mainly via our roots of the voluntary sector. So we were going to job centres, local healthy hubs, we were going to coffee mornings, we were going to libraries, just trying to get that word out there to absolutely anyone. Throughout the single point of contact, as we all know in this room, one of the biggest questions is to ask anyone you ever come across if you've ever served. So we really had no limitations on where we would go and visit and who we would go and speak to. As Harper said before, we've now made communications with Northwood headquarters. We're speaking with Carver Barracks and 254 Medical, and we've now linked in with the Barnet reservists, I believe they're RLC, because 75% of their staff come into Hertfordshire, mainly over Potters Bar. Regularly attending various different groups, as I said, continuing with communications with GPs. What have we achieved to date? I won't read all of these through because I will definitely run into lunch. As I've said, we're going through just making sure that there is that safe referral pathway within Hertfordshire that is easy and accessible to everyone. It was mentioned earlier, we're actually over that number now, over 147 referrals going on to the Veterans Gateway, and that is a mix of local services, of national services, who they are, what they do. It's just important to note that with all of them, we have made direct contact, so they know us, we know them, and we're opening up all of that communication. So moving forward, we're now looking to start really honing in on the areas that we haven't necessarily had a breakthrough and areas that we know are in need. So we're starting to look now more towards the family side of things. And this is starting at the minute with education, which is a little bit of a new venture for us. So we've now reached out to various different schools and colleges that have a specific term for armed forces families and connected with their armed forces champions. We've made contact with 5 primary schools around Northwood headquarters, and along the way with those communications, we've got our leaflet now going up on their website. The leaflet's available for the children to take home if they feel that their parents need that support, or just be able to leave it on the table and suddenly it's caught their eye, because we just need to get that information out there. As I've said, we're encouraging schools, trying to promote that as we go along. We then had the idea of going towards sport, and the more we looked into it, the more we realised we didn't know how much sport was across Hertfordshire for the armed forces community. So we've identified 11 local sports clubs now. A lot of them are family focused and they run specialised family events. We've connected with the Sainsbury's Veteran Project, and they also provide days out. So that's for armed forces families all to come together and go out and essentially let their hair down a little bit. And we've made initial contact with the Military Wives Choir, and we're now also getting flagged up with new initiatives that are coming forward. So things that might not necessarily be completely ready yet, and people are already coming to us and going, help us promote, we want to get involved, what can we do for you? So locally, those connections are just getting so much stronger. Social media in this day and age, I think newspapers don't really count anymore. So we are trying to flood social media as best we can. As you can see on the screen, we've gone to Hertfordshire military families. It seems a lot more active within the east of England, within the east of Hertfordshire, sorry. So we're now starting to try and push more towards Essex and down into the south as well. So why is it so important? What's the whole point of it? It's to make sure that no matter whether you are inside that wire or outside of that wire, you can get support, whatever that looks like to you. Especially within Hertfordshire, with our social prescribing, HCNS being one of the biggest across our local area, we've got additional links. So not only is this project run predominantly by veterans, me being one and our veteran link worker being the other, we really feel that we can understand these issues that are coming through the door. A couple of stats up there I'll let people read through because I'll get carried away. And yeah, at the point of referral into us, so into the single point of contact, I know there's a spelling mistake, just ignore that please. 90, yeah, I just spotted it myself. 90% of the people that we get through our door come through without any pre-existing support, or it is just their family support, and there's issues there and that's not quite working. So we then take that whole system approach of not just what issue comes onto our doorstep, we then look at the families, we then look beyond that and make sure we build that system up again. As I said about the extremely long email, if there wasn't an acronym, I'd need a bigger screen. We do have leaflets as well, so by all means come and have a chat to us if you just want one for your back pocket, and we can also email them out at any point. Thank you.
Thank you, Ashley. And just conscious of time as well, we've probably got 10-15 minutes for questions. And I'd be particularly interested in any of the unit welfare officers in terms of your perceptions about where you're at, but also today, and whether it's making any sense before we break for lunch. And after lunch, we've got 2 sections, an hour each, one on the voluntary sector and one on the local authority, and then we'll wrap up the day with a section on employment. So we've got about 10 or 15 minutes before we break for lunch, and hopefully a chance to relax and do a bit of networking and see the exhibitors. So happy to take any questions, whether they're online or in the room.
Just a quick question in relation to some of the organisations and charities that we spoke about this morning. Really impressed with lots of them, but quite surprisingly, we don't know about them. As police officers on the front line, we're often the first to people, veterans going through mental health crisis, be it from very low level to welfare checks to obviously the worst, which is the suicides. I'm just wondering if there's anything in place in terms of, we've got thousands of cops out there in terms of training them on this, so they're aware of this, so they're almost like your champions, because we go to other LGBTQ plus and we hand out leaflets, we know who to refer them to, but I think we need to try and sort of figure out how we can get this information directly to the cops that are going to be dealing with the veterans.
It's a very good question, and it's something which each area struggles with. So we have got a lot of fragmentation. We've also got quite a lot of duplication. I mentioned earlier the Veterans Gateway. That's an app you can download, and that's one of the reasons why we've pushed on it from the point of view of trying to update 147 services that are available in Hertfordshire and West Essex and put them on the app so they're up to date. So any of your either your frontline personnel or anybody in the community can download that app and do a search in terms of what service they want, and it'll come up with the nearest local service. There is another app called Forces Connect. So there are different ways of doing this, and I know, for example, in Norfolk, the local authority has got a very good directory of local services that you can go to. One of the things is it costs money to obviously keep things up to date, and it's also down to individual service providers to take responsibility for making sure that the information is up to date. So if their telephone number changes or their contact changes, but without a doubt, it is probably one of the key things, which is I'm in awe of the range of services that are out there, but very few people see the total range of what is there. As I said earlier on, there are some very, very good, very specific specialist services in the voluntary sector, but a lot of people are not aware that they can access them. But you're right, if we've got, and we'll talk about this with the Health and Justice and the Opnova and the healthcare in prisons, it's exactly that. There are some very good dedicated services out there, but a lot of people are not aware of them. So I'd suggest use the app, and if it's not working for you, we need to make it work.
Hi again. This might be covered by another presentation, but I just wondered about street homelessness and whether you hold any form of statistics on that, and also the connectivity between the Veterans Services and Gateway to local authorities and their teams that are specifically dealing with this issue.
It's a good question, Ian, and I don't know enough about it. I have to say it's an area where we don't have a lot of accurate information on it. I'd look at, this is how we should be putting the Joint Strategic Needs Assessment together. Matt's he's got the numbers.
Well, I haven't got the numbers necessarily, but if you need the numbers, it's the University of York that are doing a lot of work on homelessness. But street homelessness is just one aspect. Homelessness is like, sofa surfing and everything else. So that's just be a bit aware that when we look at homelessness and veterans, actually there's more veterans that are non-UK veterans that are street homeless than there are UK veterans. So it's but yeah, University of York.
I was just going to add on top of that, there is the OVA working on a veterans housing strategy pathway, and there is also part of that coming up soon, starting on July 3rd, is Op Fortitude. So that is a funded program where it'll look at supporting individuals that are street homeless or sofa surfing, and that's looking to go live on the 3rd of July. So that's also something that DTS is linking into as well.
Yeah, I think that's a really good point. So the Op Fortitude being led by the chief exec of a charity called Riverside, Lee Baz-Blair, he's linking directly in with the Office for Veterans Affairs. From an NHS perspective, we want to join up the the city-based in this case, and I know that the rural issues are probably more pertinent in some part of this world, adult mental health teams that are actually delivering into that rough sleeping and homeless area already. They're already upskilled and aware of the veteran part of that issue. But I think Matt would probably also want to mention the fact that some of these are youngsters who are sofa surfing but haven't quite settled exactly where they are. Some of them are more itinerant and therefore have got into living rough, and it's about getting them back to engage with the NHS system when we need them to. And then there are individuals in crisis, and there are a number of those individuals in crisis who are also needing other parts of the service into substance misuse, alcohol, drugs, and various of that. I'm not trying to categorize them, but I think it's an issue that we just want to be aware of. So the Op Fortitude is very much about bringing that element together, and we're all looking to support that initiative through our services.
Thanks, Richard. And I think it goes back to a point I was trying to make earlier on, that this is about having a good handle on your local needs assessment and knowing the numbers and knowing where some of the issues are. And they'll be hidden. You know, they won't be obvious, but actually it'll be frontline staff, both in the voluntary sector and in social care, who will know where some of the, the hidden problems are. So one last question, Joanna.
Johanna Hoots, or JJ, Milton Keynes Armed Forces Covenant. I don't know if there's anyone here from Northumbria University who might be able to help with this one, but it's about the Veterans Gateway. So I spent a lot of time over the last few years putting a lot of stuff on there. And the app's disappeared from the App Store, and even when you go online, I can't find a single thing that I've already put on there. I thought it was just me, but my colleagues here have just been furiously looking. So I think there's a problem with it, but I know Forces Connect is very much up and running, but you need to register for that. And there's a lovely lady called Jenny Noakes from the Sussex Partnership who runs that. So if anyone wants to get on, I know at Thames Valley Police, every Thames Valley Police officer now has got a phone with the Forces Connect app on it, and that can be kept up to date by regional people. But if anyone, I know, Bev, you had your hand up there about Veterans Gateway, help out.
My understanding is it's under review, it's being relaunched and whatever, so it's taken down at the moment, I believe, from the Veterans Gateway, but their online information
I still can't find anything
there.
Online.
Well, yeah. Well,
I think we've identified a problem. I agree. It is something that I was trying to get as part of this conference and struggled. So we had taken the view locally when we looked at this. There is duplication, both in terms of local authority and nationally and the voluntary sector. What we need is someone to actually have a review of it all and make sure that we're all working with the same standardization and the same product, because what we don't want to do is that confusion, both for professionals as well as for the public, about how do you get a decent directory.
Sorry.
One last one, go on.
Yeah,
Then.
I just want to add about the Forces Connect. It's great, and the Veterans Gateway, but we're east of England here. Unfortunately, not all local authorities link up to these. So it really needs to be recorded that every local authority within the east of England are using these facilities, because where I come from, they don't whatsoever. And I actually brought this up with them 2 years ago, and they've still not moved any further forward. And that's an unfortunate thing, because when veterans need help, now digitalisation is the main thing to go to. And it's only as good as the people who buy into it.
Absolutely.
I'm sorry, that wasn't a negative point. I'm just
No,
trying to...
it's a problem-solving issue. So we've got a problem, let's solve it. Absolutely.